because it's bleeding every time. We are walking, we are sitting. Also, when we are moving in the bed, the calves contract. And this contraction could give you an high percentage of displacement, a really high percentage of asymmetry, and the scarring, above all, also if you are super skilled, we are not talking about soft implants, we are talking about medium hard implants, so you need a little bit more, bigger point of entrance, so the scalp is much more visible if we compare to the little point that we have injecting from the lower part to the upper part with a shape. The learning curve is the same that we have for the buttock injection, and for sure is safer and less invasive than a surgery. The recovery is really fast, and the downtime is really minor if we compare to surgery. If we compare with the buttock injection, we can see the touch-up in this case is really easy, and sometimes you don't need that. Or if you need that, maybe it's just really minor, just a bite, just a syringe. The candidate is the patient with undeveloped muscle or with congenital small muscles, or small calves, or the one who are not responsive to targeted exercises like me. I can do tons of exercise, my calves will be the same, because it's much more tendon than muscle belly. This is important, and sometimes these are the patients that will come to your office to ask for a calves reshaping. If this patient had previous treatment with permanent filler, had bad vascular disease, or suffer from high level of diabetes, I don't suggest you to inject, but I don't suggest you to treat in any case. The treatment protocol is quite the same that we use for the body filler. The most important thing that changes the product in the calves, use always MF1, because we have a thinner layer, so we need a softer filler. Softer filler, that doesn't mean that it's not going to voluminize as we want, because in this case we are going the muscular shape and a little bit to voluminize. So MF1 is perfect for this area. And also is moldable, and it's softer also when you work, when you touch. This is really important. The second step is that you have to make a fixation and maybe trying to convince the patient to take it up to 7 days. Sometimes the fixation could be loose, so my suggestion is to change it after 3 days, make the patient come back to your office, control it, and do one more session of bandages, maybe lighter if you want, but for a week, the week is my suggestion. What is the other point to struggle? The quantity. Don't try to inject more than 3 vials at the beginning. I think you all know what is a compartment syndrome. If we put a big amount in such a thin volume, we could have a pressure on the muscle. The muscle will react with inflammation, and will react by having a blood flow so big that you need to make incision and to remove the pressure. So to avoid this, if you are focused on injecting on the first time 3 syringes, that in my opinion is much more than enough, you could, in the second time, maybe make 1 syringe more or 1 syringe and a half if you need, because sometimes it doesn't. The side effect is the same that we could have with the buttock injection. For sure, we are using a softer filler, so also nodules could be less common. This is the pinch that I told you. You do the pinch test, you pinch the skin, you go inside like you see from the lower part is my suggestion, not from the upper part, because the only anatomical danger zone is the popliteal crease, because we have important vessel here. We have the vessel really big. It's really hard But if you are not skilled on the area or with the cannula, so if you are going from the lower part, you never feel. You feel the lateral compartment, check because of the computer is always when you are with the tip, because we use the same cannula, e.g. 10 centimeters, that led us from a single point to arrive everywhere. And then you put that, this kind of projection. Usually, if the patient comes to your office, one after the result like this, one improve the medial contouring, or one improve the muscle belly sometimes, when it also maybe is 70% a male procedure, but I got some woman patient that want more the contouring because they all the leg is too big, and so they want to achieve a good harmony, giving much more projection on the medial side. The last but not the least is one of the most requested procedure today, that is the angiorejuvenation, because if we are good in the face, we are amazing with neck transfer lifting or skin boosters, and could give the real age if you are not treating it. Why? Because when we are young, this is the aspect of our end. We have a good percentage of subcutaneous tissue. That means no pigmentation, good skin quality, no visible tendons or vein, also in hands like me that are super skinny. We have also absence of skin flexibility. We like to have this, if we have this kind of hands, nobody knows what is our age. But when we grow, we are running to this point. So if we want to avoid to have this kind of ends after 40 years old, after our 50s, we need to avoid the absence of the subcutaneous layers. The absence of the subcutaneous layers, what does it mean? It means that we have the deterioration of the skin quality, we have the tendons and the vein really visible, and we have a really improved flexibility of our skin. So it's a matter of giving back the subcutaneous tissue. We, like we did in our previous step, we have to have a look a little bit of anatomy. This is just to show you how complex is the anatomy of the hand, but it's not our case. We are not hand surgeons. We are just injecting the superficial oil. Also, if we do, if we have super skin, we don't need to arrive here, okay? We just need to arrive up above on the tendons. Here you could see, I want to show you before this and then show you the vascularization. We are going to inject in the subcutaneous space. We can inject also the subaponeurotic space because there's some loose fat. But we have to inject the subaponeurotic space only between the tendons, okay? This is really important. The subcutaneous space is important because it gives us the structure that I told you, it gives us the placement for the muscularizing effect of the hyaluronic acid, and sometimes it gives us also the frame that a elderly hand could lose by the time. These are the veins that you will reach with the cannula. The blunt cannula, usually, if you are going smooth, doesn't maybe hit, but pass by, up or down the vessel without having any trauma to the vessel. It depends only on the technique. If you feel that something is not going, remove it. Find another place. Find another layer. Maybe you are not in the right layer. Or maybe you have some fibrotic tissue. We all know that a lot of try to inject with calcium hydroxyapatite. That is not my favorite, because at the time that you stop injecting it, you have a lot of fibrotic tissue. So if you want to inject also the face, so you cannot do nothing that led to a vascular occlusion here. The only problem is that you're not so soft, or if the patient has maybe fragility on the vessel, you will have hematomas. But in the consultation, we tell the patient that could happen and nothing could give you such bad complication. So as I underlined before, we need to create new subcutaneous tissues, and we need to create new subcutaneous tissues when the elective candidate is patient after 4 days. Sometimes patients who suffer for skin, bad skin quality because of the pathological disease, or bad skin quality because of the traumas, tumor resection, or burns. That could be really common when you do this procedure, and I will show you later. The injection of anesthesia, despite of the injection in the buttock, is one entry point, injection, blanching, iron section, and several small points all around the end also. Just a little shot of 0.1 cc, just to give a little bit of hydrodissection and to control the pain, because sometimes here I'm using a TG also here. We can use, because we are using MLF1, so the smoother, also 20 if you want. But 20 could be a little bit harder. You have to know this. If you are not skilled, use 18, otherwise with the 20 you are wasting the way you are injecting, okay? So you would have a little bit of it, because sometimes you are tired, so you will die a little bit the pressure and you will have small nodules. Here, like in a rhinoplasty, when we are performing rhinoplasty for surgery, in a surgical way, sometimes we love patients with thin skin, because the result is amazing. But if we have a little bit of bad scarring of the bone, or a little bit of asymmetry in the position of the cartilages, the thin skin will show this. The same is in the end. If you do boluses, the boluses will be too visible and the patient will complain. If you do linear retrobracing technique, we create the new subcutaneous tissue like a layer, and we don't have any complaint, but we have patient super happy. This could be the technique. We have to inject, and I will show you in the video later, in the interdigital spaces. That means between the tendons and in the lateral and medial area if we have skin flexibility. The important is to start from the wrist and stay on the wrist. You don't need to have, I saw around the world a lot of entry points by the interdigital spaces here. I don't know why, because you are making 3 traumas, you are making 3 holes, 3 anesthesia, 3 times of pain, and here we have the major vessel, and here we have also the nerves. So if we hit the nerves, sometimes it's a tumor, sometimes could be a trauma, and we have paresthesia, that is the worst complication that you would give a patient that comes to treat the skin of the mind, of the hand. These are the healing process. Every patient, like I told you before about the gluteus and the calves, will have redness and swelling in the postoperative 24 hours, also 72 hours. Usually it lasts 3 days or 5 days, and then we will solve. And also the paresthesia could appear, but it will solve. Don't be scared if the patient says, oh, my hand is swelling the day after. Yes, we need a treatment. You have like a thin layer like this, because we are talking about people that maybe has skin quality and skin structure. Sometimes patient comes to you that are 70, 75, and the skin is really thin. Maybe you do also hematoma, so increase the possibility of treatment. just you have to know that everything is quite normal if happened in the first 24 to 72 hours. These are some before and after. You see how we succeed in covering the tendons, how we succeed in covering the veins, how we succeed also in the skin quality. You see the skin is more luminous, the skin has also less pigmentation, and also we give structure. Okay, you see how we create subcutaneous tissue, also covering all the stuff. This could be patient like this, where you need surgery because the skin is damaged by a burn, so the skin always have ulcers. We decided to do surgery with the skin expander and to achieve a good result like this. The patient is happy. We treated after this the syndactylia between the third and the fourth. The patient is happy. She doesn't have any ulcer. She doesn't have any retraction. But what about skin quality? It's not that good now. So we say to the patient, start injecting with some chain. We are not asking you to have all the traumas that you have for the surgery and for the other stuff. It's just injections. See in after 10 months how we improve the skin quality. Now she has a skin. You can say that it's for sure she has a trauma, but the skin quality really rise up thanks to the injection of hyaluronic acid. Now I'll show you a short video on the technique to use. I'm always happy to stay with the advisor stage. That is one of our, that is the main doctor of the board. You see, he is now assessing how to inject the end. One important thing for the post-treatment protocol is to strangle to the patient not to stay in the first 48 hours like this. Trying to, she doesn't need any garment or any suspension, but tell her try to stay up with the end, because that's when it is a lot if she stays for an hour like this. You see, he underlining all the area to inject, is underlining the different interdigital spaces between the tendons, and is underlining also the limits of his injection. Okay, this is really important, because when you go with the camera, you have to go deep up to the interdigital space, because if you come from the wrist, nothing could happen. You will see how he will do the anesthesia. He decided to do an anesthesia in the entry point, in the interdigital spaces, and a little bit on the dorsal of the hand. We use the same anesthesia with the same needle just to do the skin blanching and the eyebrow dissection. The eyebrow dissection in this case is really important, because instead of having an entry point with an 18-gauge needle, that in the case of the buttock we can go deep without problem. Here, if we go just after the first step deep, we can hit a vessel, we can hit maybe on the wrist tendon. So it's just with the eyebrow dissection we create that ballooning that give us the possibility to put the entry point, avoiding to hit any underlying area or underlying area. You see, you put the 18G cannula. Sometimes in the hand you could use for sure the 10, but now we have a lot of cannulas with different length. So in the case of them, you could choose the 5 centimeters. I don't suggest you the trick because with the we can go all around. You see how he injects. Usually every tunnel you create, you are putting up to a total amount. My suggestion is for the first injection of 3 cc. Because the vial is 10, but it's better to save and to touch up with the last 2 or 4 instead of injecting too much that could give you a long-lasting swelling, because it's softer but it's always macromolecules. So inject less and then massage, like he's doing like this. Okay? After the massage, you will see, you will control how everything is going. If you need to touch up a little bit, massage again, put just a steady strip on the entry point and tell to the patient to massage softly in the next day with polysaccharide cream like the iodide or anti-hematoma cream that could give her a little bit of effort if she has a little bit of pain and could help to contrast the swelling of the end. The last indication is for concavities. Concavities and deformities that you could have because of genetic aspect, or concavities and deformities that you could have after wrong technique of liposuction, where the surgeon used a technique that is maybe too superficial, and you have some remaining superficial tunnels that are like scuffs. In this case, if you are not doing a detaching of the retraction of the fibers, you could use a normal cannula. Otherwise, you have to use a Toledo cannula, the one that cut all the fibers and the septum creating by the bed scarring, and then fill. This is really important because patients like this really don't like to go back to the surgery room to do one more operation to repair the problem from the first operation. You suggest them to come to your office, just lay down, anesthesia, 15 minutes procedure, a little bit of bandages for the migration. Here is really important, but it's not so uncomfortable like it could be for the buttock or for the calves. And inject always, in this case, MLF1, because you could have cases where you are really superficial. You smooth and you mold the MLF1 along the area to treat, and the patient will be happy with really a good compliance. Thomas talks a lot about the range. We talked about the range, but just to refresh a little bit, we have 2 main products. The MLF1 is the smoother, and the MLF1 is the one that we can use also in the buttock where we need to shape instead of volume of needle and is indicated in the leaflet for calcium correction of concavities. The MLF2 is the buttocks, and in my experience, I also use for the pertussis scalatum instead of making a custom implants that has such a lot of difficult post-treatment protocol. Thank you so much. I saw that we are strictly on time. I hope to give you a wide lecture on all